Are there some similarities?
Yeah, so
For years, I suffered with lipedema. It affected so much more than just the cosmetic aspect. It affected my relationships, my job, my mobility.
It's not all about the aesthetics. It's about restoring quality of life. It's about relieving pain, and it's about restoring the patient's confidence.
It's not just about how I look, it's about how I feel.
We've treated over 3,000 lipedema patients from all over the world. They come from all over the United States, from Australia, from UK, Canada.
Lipedema surgery has given me a whole new lease on life.
Right now, I feel unstoppable.
My name is Dr. Sue, and this is ArtLipo Lipedema Surgery.
All right. Hello, everybody. I'm Dr. Sue, and
hi, I'm Dr. George Kardashian. Hi.
And so welcome to the ArtLipo Facebook Live. This is our second one, and maybe you've had the opportunity to join us for the first one. This is Dr. Kardashian, our new surgeon, and I'll just give him a second here to introduce himself to those of you who haven't haven't known that he's joined us.
Yes, I'm George Kardashian, and I did a lot of my studying in orthopedics, where I went to medical school in New York, and I did my orthopedic surgery residency program in New York. And then I specialized in surgery of upper extremity and hand in Miami. And since then, I've been in practice for the last 14 years until a couple of years ago. We talked with Dr. Sue about pursuing a different path.
So George has been training with me on and off for a little over 2 years now, and we've been actively doing things together here and working on patients together for about 6 months. And it's been about 3 months now since he's been doing cases independently. So I've been very, very happy with his results. And if you guys have seen some of the comments from patients who have had their surgery with Dr. Kardashian, then I think you'll probably see that they've been very happy with the results also.
Yeah, and over these last 3 months, I feel like I've grown tremendously. I love the results, great results, and I love seeing patients' reactions to these results.
Yeah. So just follow us along on our Facebook, and you'll get to see the before and after results and videos, because we're doing quite a few videos with Dr. Kardashian's cases, so you can see the immediate results afterwards. So I guess without further ado, I just want to make some comments about the Hurricane Milton that just hit Tampa, Florida. We are still kind of recovering for this. It was just a couple of days ago, and we have a lot of power outages all over the city. Fortunately, the ArtLipo office, we have not lost power, and I think we're, most people here were fairly safe, but we're inconvenienced by a lack of electricity right now. So I just want to mention for the patients who are on our schedule for this coming week, we are operating. I think the only holdback is that if you have plans to stay at a particular hotel already, which you need to have, some of the hotels may not have power. And I'm hearing from our electric company that it may be another 4 or 5 days before all the power is restored. So it's very important that if you have a surgery this week, that you call your hotel or the recovery house and make sure that they have, they're confirming that they have power and have a place for you to stay. Otherwise, everything is good. We have all our staff and everything here. So
no flooding.
Yeah,
no flooding.
Yeah. We're so grateful that the Tampa Bay area did not get hit by the huge surge of flooding that was anticipated, but we were spared. So we have a lot to be thankful for here.
That's the big one. Yeah, yes. Absolutely.
Yeah.
Absolutely.
So this is a opportunity for our patients to ask questions, and we've already got a list of questions that we've been receiving all morning here. And I think we'll just start answering some of the things that as they come. Okay. So I'm going to pick through some of the ones that we haven't answered on our last one. And then some of them may be overlaps because we've already covered a lot of this stuff. This is Danny. Danny asks, does this treatment typically leave patients with loose skin or lumpy fascia? And what I can tell you is that it can. And we treat all types of patients, from young patients who are in their early to late 20s, all the way up to 70. So you can't expect someone who is in their later years, in their 60s and 70s, who already have loose skin, lumpiness, bumpiness, and everything, to come out with better skin. In fact, we are always hoping when we do a surgery that we'll have at least the same smoothness. In some cases, it'll be a little bit better, but that's typically going to be your younger patients. So our older patients definitely will have some looser skin in certain areas. And skin after liposuction always has some reserve for elasticity. That means that it can, when you remove the fat underneath, the skin will pull together. It always happens. But someone who is 60 years old has a very small reserve of elasticity, whereas someone who's 30 years old, it's going to pull back almost all the way with very minimal looseness or wrinkles. So that being said, when you send us your photos, we do our evaluation based on your photos. And I can already tell by my years of experience working on the legs and arms, I can tell to a large extent how much looseness there's going to be. And what we do with our virtual consultation is that we will draw on your photos, and I make comments on the side saying there's going to be mild looseness in wrinkles, or I may say moderate to severe looseness in wrinkles. And it's not just written there. It's also, I use, my marker and my pens to create little a drawing of where the looseness will be, to give you an idea. So I know this doesn't answer all of your questions because a lot of people have a hard time picturing what that would look like. And then I think that even after they hear that there's going to be looseness, patients often ask us, well, can I do something about that looseness? Can I exercise and make it go away? And unfortunately, exercise is not going to make your looseness go away. So we have multiple conversations, from the initial drawing and what I mentioned to our consultants answering questions over and over again. We also have a conversation at the day of your surgery when you're in person live with me. I'm usually looking at the skin over again and confirming what I've already told you. Okay, so we don't just jump right into surgery. We spend another 30 to 45 minutes talking about what we see in person. It's very rare for what we have told you and prepared you for beforehand to be different from what we see the morning of surgery. I think it sometimes is easier for patients to understand when we're having a conversation one-on-one, at that time, to really go into detail, explaining it multiple different ways. Patients say, well, how much looseness is going to be? And I'll say, well, if you're 50 years old right now, imagine your skin looking like it's 60 years old in certain areas. Okay. On the inside of the thigh, it's the skin is the thinnest and most easily to wrinkle there. The rest of the frontal part of the thigh, the outer part of the thigh, the back of the thigh, those are areas that don't usually wrinkle very easily. And also the lower leg, the calf and ankle areas, are also much more resistant to getting wrinkly. So only in the largest patients and older patients will we see wrinkling around the calf and ankle area. But there's usually always some looseness there to begin with. So
and also, yeah, if you stand close to the mirror, you really see the wrinkles and the looseness. But the farther away you get, it's hard to see. And I feel like from far away, it's much easier to see the bulk that went down.
Yeah.
and so the price that you pay is you do get wrinkles, which
Yeah.
which are harder to see.
So I like what George was saying here about, the further away. If you're looking right down at your leg, which is only like 2 feet away when you're bent over, wrinkles are easy to see in that closeness. What I like to do is, when I'm standing a patient in front of a mirror, which is what you likely do at home, if you're standing 3 or 4 feet away from a mirror, I would say mild wrinkles are very hard to see at that distance. And if you're 3 to 4 feet away from a mirror, that's actually about 6 to 8 feet distance from, someone else. And I'm imagining how it would look to someone else who was standing close to you. Would they be able to see the wrinkles or not? And if you have mild looseness, it's going to be very hard to see because these areas are also in a little bit of shadow. If I say you're going to have moderate to severe wrinkles, yes, you're going to be able to see some wrinkles from 6 to 8 feet away. And I think there's also this confusion about what wrinkles are versus sagging skin. Rarely do we have anybody that has skin that's sagging and folded over like a shirt and hanging down. That would only be in someone who is already bunched up. And again, I had to go back to the inner thigh, because when someone's standing from a mirror, you can sometimes see if their skin is really loose, it'll be wavy and kind of folded upon itself. That's already very severely loose. And we can say for certainty that there's going to be severe wrinkles and some of those folds remaining afterwards. So if you're starting off with no wrinkles or very little looseness, it's still typically going to be only a little bit of looseness afterwards. And one of the nice things about how we sculpt things, and we are very meticulous about sculpting the fat close to the skin, and that's removing the fat right up close to the underside of the skin, is that the skin retracts a lot better. And even if the skin has some looseness in it, when it drapes over the muscle, whether it's on your inner thigh, outer thigh, above the knee, or down over the calf, wherever it is, if that skin is draping, pulls together and is draping over the muscle underneath it, it's not flopping around as if there was fat, because I call this jiggliness. Okay, when you have a thick layer of fat on your inner thigh and you walk, it's jiggling and it looks really loose. However, when that fat is gone and now the skin is laying smooth, it's laying directly above the muscle, it's not jiggling as much, and it actually looks tighter on many people. Even though we haven't improved or tightened your skin, it just doesn't move in that loose appearing manner. So let's see how I can wrap this up. If you are concerned about looseness and wrinkles, and I think it's very common question, and you rightly do want to be concerned about it, pay attention to what we inform you of, what I write on the drawings themselves, what our consultants are telling you. And then when you get to the office, really, be prepared to have what we talk about. I am someone who always tells people what the worst case scenario is. I think that's the best thing to do. If we turn out with tighter skin than what I prepared you for, that's only a good thing. So we never want to come out with a case where you have worse looseness or some other negative factor that we haven't prepared you for. That's about, the age-old statement of under-promising and over-delivering. That's, we always want you as the patient to be prepared for things that are going to be negatives. And the positive is going to be there too. You're going to be slimmer and shapelier for certain. The skin is the thing that, since we can't exactly know what it's going to be, I always tell patients it's going to be a little bit worse. Anything else?
No. This is, I think we talked a lot about wrinkles.
So that's looseness. Bumpiness. Bumpiness comes from a couple different factors. And if you think about a woman who has cellulite, that bumpiness can be on the front of her thighs. It can be on the outer part of her thighs, inner thighs, and all the way down to her legs. It's hard for me, even though I've been in this for such a long time, been doing the legs and arms as a specialty for 12 years. And when I learned about lipedema 6 years ago, I've been trying to learn and distinguish what's the difference between normal cellulite and lipedema nodules. And I'll tell you, even though I work with patients day in, day out, it's hard for me to actually distinguish between the two sometimes. So I don't pay a whole lot of attention to saying this is exactly lipedema nodules or this is exactly cellulite. I don't try to make that distinction. As you know, if you think about it from my standpoint, my job is to get rid of it and get it as smooth as possible. But what I want to tell you about the question that Daney asked about the bumpiness, sometimes it improves and sometimes it does not. Okay. As a cosmetic doctor that's been doing this for 18 years in all areas of the body, the bumpiness from cellulite, I've always told patients, don't expect it to be any better. I mean, we're lucky if we don't make it worse, because most doctors who do liposuction from a cosmetic standpoint will always tell patients that that their cellulite could look worse afterwards. In my own experience, and I think it's because of the way that I do things superficially, coming up to the surface of the skin, and that's different from how every other doctor is taught out there. So I am doing something very different, and we'll talk about that in just another question. But when we treat things very superficially, the bumpiness of that surface fat sometimes gets better. And I'm going to give you a guesstimate. It's about 50% of the time that I see bumpiness look somewhat better. So I always start off now with my lipedema patients telling them, if you have bumpiness and nodularity that you can see and feel, and you know, it looks bumpy to begin with, expect it to be the same. And if it gets better, that's just a bonus. And that's all I can tell you, is that it could possibly be better, but don't expect it. And on that note, I know some other patients were asking about nodularity, and this seems to be a very common type of question. Nodularity. If you feel nodularity now, that it could be it could be a sign of lipedema, and it can also be just bumpiness from cellulite. But don't expect all the nodules to go away, because as I've been treating lipedema now for 6 or more years, depending on how you look at it, 6 years knowing it, and maybe another 6 years without knowing it, those lumpy and bumpy areas that people feel don't all go away. And I've had patients contact me months later and say, Dr. Sue, I don't think you got it all, because I still feel some of the nodules. And that's not how it works. We will remove the majority of your fat. And what we do is very complete. And we get about 70 to 90% of the fat. And even when we get all that fat, doesn't mean that all the little bumpy areas are going to be gone. Some of those bumpy areas are from fibrotic connective tissue. And that's all the mesh work that goes, surrounds the fat. This is your fat layer. And then you have all these little fibers, and those fibers become thickened and stiffened to a state where we call it fibrosis. Everybody has those fibers, but they can become stiffened, and then you can kind of feel it, especially when we're moving through the fat with our instruments. The difference between a normal person, where it goes just kind of steady, versus where it's catching and hard, that's what we call fibrotic. And it is the case in some of the more advanced patients with lipedema, not all patients. Many of the patients that we treat, it doesn't feel that much different from a normal cosmetic case.
Definitely, definitely makes it harder for us to work with a cannula, and we get the fat in between. But those fibers, especially as they heal, they give you that bumpiness that we cannot get rid of, and that's what I think that's what you started saying.
Yeah, some of the bumpiness that you feel is just from the fibrotic
fibers,
fibrotic connective tissue. So that was a great question, Danny. Lumpiness and looseness are our biggest concerns outside of removing fat completely, and we can get rid of the fat very completely, but we can't get rid of that fibrous, lumpiness. All right, so let's see. Sepperson asks, do you lipo other areas such as the abdomen and neck that are showing lipedema nodules? And I think we kind of answered that before, about the nodules. Nodules themselves are not the most concerning thing. It's about, removing the majority of the fat. We can remove fat from any part of the body, basically. And I've done almost everything. I've done from the back of the neck, which is buffalo humps, all over the back itself, not just the neck, but all over the back, all the way around the chest, the waist, arms, down to the wrist, all the legs and buttocks, all the way down to the ankle. So, and even onto the little parts to the sides of the feet that get the fat balls, or ankle balls, as many of our patients call it. So if there's fat and it's kind of sitting in a thickened area, we can do just about anything. Now, that doesn't mean we will, because there's some areas directly behind the knee that have major arteries, nerves, and veins running behind it. So we have to pick and choose what is a safe thing to do. And usually I will not get aggressive working right behind the knees. On a few patients where it's really thick, I will go in there and get it. And the same thing on the sides of the feet. Patients, I think in our Facebook group, there's been a number of discussions about ankle balls and patients with lipedema. I'm going to raise my foot up here and see if we can get right on the sides. Hold me up here first. Right here on the sides of the below the ankle bone is a little bulgy area that a lot of patients call the ankle balls. And I think it's a normal fat pad for everybody, but in cases of lipedema where the fat's really accumulating a lot around the ankles and even the sides of the feet, they can become prominent. And we usually go after that. But in some patients, I would say my elderly patients, 60s and 70s, that skin is so fragile. And because all of the swelling accumulates down there, it's just an area that makes me nervous sometimes to address as completely or aggressively. So don't be surprised if during the surgery you come in and I say, well, you know what, we're only going to get about 50% of that fat, because it's also very fibrous fat in many cases, and you don't want to be scraping with this instrument aggressively in an area where the skin is thinner. It's harder to heal. It's going to be experiencing a lot more swelling, and also it has tendons. This is the guy who knows tendons. So
I know all about the bony prominences, joints, tendons, ligaments, nerves, and all the muscles.
You don't want to injure those, right?
Correct. You don't want to injure any of that stuff, and that's what gives us the advantage here.
Now, one of the things that I think we're always very careful about, structures that we don't want to injure. One of the things I just as we're on this topic right now, is that our technique, which is a superficial technique, you heard me say that a few times, but if you can imagine, this is my hand sitting on top of the fat, and instead of pushing everything down and scraping the fat away from a downward force onto your muscle, we're scraping upwards. Okay, so we insert our cannula and we're working that fat kind of in a sideways direction, but always with that pressure upward. And the importance of this is that the dangerous structures that we don't want to hit, which are blood vessels and nerves, are down on the bony. They travel over the tops of the bone, over the muscles. When we work around the arms, they're down into the groove around the elbow here. These are things that you don't want to ever be pushing down on. And our technique is an upward technique, which does put the pressure against the skin, and it scrapes that fat away from the skin, which is to our advantage when it comes to skin tightening, like we mentioned before, that allows the skin to retract better. But I found that the skin is also very resilient and does very well. That's what I've been doing for 18 years, is this more superficial technique that I would hope that more doctors learn to do that, because it's a much safer technique on the tissues below, and it also allows us to get things much more completely. I think that someone else had asked a question, and this was Alicia's question. She says, why is Dr. Sue's lipo technique, what is Dr. Sue's lipo technique that the skin remains tight and retracted where other surgeons' skin sags? So this is a good time to kind of lead into that. And when all doctors doing cosmetic liposuction are taught how to do it, they're all taught, go down deep. Okay, so this is the surface of the skin. They're taught, go down deep, stay deep, leave the layer of fat that's closest to the skin alone. And they're taught that because they are taught that if you put any kind of scraping motion against the surface of the skin, that you're going to injure the skin. And what I found from 18 years of experience is that doesn't happen. Skin is very resilient and very strong. And you don't want to leave that layer of fat behind, because the fat that's stuck to the surface of the skin actually keeps it from pulling together. And the minute, as soon as you remove it all, that skin is able to pull together because it has nothing holding it. So when you take so the technique that other doctors do, here's the surface, they're going down deep and they're removing 50-60% of the fat, which is pretty typical, down deep. Now the skin has a layer of fat, maybe a quarter of an inch, a third of an inch, sometimes even half an inch underneath it that's stuck to it. Instead of pulling together, it goes into a flop. So imagine on the inner thigh where there's this layer of fat stuck to the skin, it can't pull together, so it just droops. Or on the underside of the arm, it just droops and it hangs. So that's what other doctors experience. They go, well, the more fat we take down deep, the droopier the skin gets. And if you were to remove the rest of the fat from close to skin, you'd see that that skin pulls up to a very significant degree. This is not a technique that has been taught. It's a technique that was described a lot in the 80s and 90s called superficial liposuction. The vast majority of plastic surgeons and all the teaching shied away from that over the last 20 years. But I'm telling you that that is the difference between what I do and what the majority, pretty much all doctors are taught when they're in residency or in their training settings to do. Stay away from the skin. So in any case, we enjoy a huge benefit as far as completeness and skin tightening with our technique. And I think there's a lot of doctors out there. If you've seen any doctors that have really large, areas that have come down completely, that's because they did everything very completely, including the superficial layer. And a lot of doctors don't even know that they're doing something that is based upon superficial technique and the skin retraction that comes along with it. So,
and we do take deep fat as well, in addition to superficial.
Correct.
And that's what makes it really complete, ultra complete.
We work from the top and we work down, and as we go down, and everything comes down, 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 down. So it's not like we skip the deep fat. We get the deep fat too, but we're working it from the surface. And from when we're done, we're about 70 to 90% complete with the removal of the fat. For those of you who are wondering, why don't they take the last remaining 20, 30% or 10% of the fat? Because it becomes much more difficult. If you have a layer of fat like this, and that's the skin, you have a lot more connective tissue and fibrous tissue up there, and you have a lot more down here. The middle layer of fat, I call that the easy layer, okay? Because it's just the fibrous bands are not as concentrated. So that's why most doctors are working right there in that middle layer. It comes down. Okay, it starts getting difficult when you get done with this. the remaining fat that's superficial, it's very difficult to remove. You got to apply a lot more pressure. And if you don't know what you're doing, it comes out irregularly, meaning, okay, you get a little bit here, a little bit there. So now you run your fingers across it and it feels lumpy and bumpy, not smooth. One of the things that we have, George and I do to avoid this is that we have an interactive technique. This is something that I started doing close to 18 years ago. I would have all my patients tighten their muscles. So whether it's the arm that we're working on or the thighs that we're working on, if that muscle is tight, you can grab everything and you can pick it up off that tight muscle and you can lift it up so that all the pressure is moving upward. And you can also control it to such a degree that you can move your cannula across it smoothly. Normally, when tissue is loose, you go into it and it wants to send you down or off to the side. The connective tissue is jaggedy, so it makes it hard to move your cannula across it smoothly. But with our technique and patients tensing up their muscles, we can control it in a different manner than that is not available to the doctor who's doing this under general anesthesia. They will never have the same amount of control with the same skill set. I mean, I've been doing this 18 years, so even in looser tissue, I still manage to do a little bit smoother than most. But hey, you want the most advantage you can get. So for whatever skill level someone's at, it's going to multiply their control greatly by having them tense up their muscles. So, what do we say all case throughout the entire case?
Tighten up the muscle. Tight.
Tight. And so by the time you're done with your case, you'll be a little worn out because we call it a boot camp. It's Dr. Sue's, actually, it's the ArtLipo boot camp, where you're actually doing a workout that is helping us do the best job for you. So yeah, you want to give it your best effort.
And so that's one advantage of wide awake liposuction, and the other is just safety. It has a much better track record of being a safer procedure versus general anesthetic that can give you a lot of other complications. And in addition, like Dr. Sue said, it is interactive, and we can have the patient tighten up their muscles, and we can have the patient stand up and use gravity to show additional areas that we need to work on. And so that's a big advantage.
Yeah, I'm trying to find the question. There's a patient that asked, a question about safety. This is Milan. Thank you, Milan, for asking this question. She said, I don't know if there's a risk with, no, she says, I know there's a risk with any surgery. Is there a high infection rate with doing awake lipo? So I'm going to expand upon this question, just talk about safety in general, as George already started talking about the safety compared to general anesthesia. Infection is something that we have to prepare our patients for in any kind of surgery. All doctors will tell their patients there's a risk of infection if there's anything that even breaks the skin, even a needle. So fortunately, I can tell you that the rate of infection or the risk of infection is very, very low. And I'll just give you an idea. This is the best way I can say it. I treat about 500 patients a year, do about 500 surgeries a year. I would probably have about 4 or 5 patients that call me with a reddened area, a small reddened area around an incision site, which it's hard to even call that an infection. I mean, it's maybe a very early infection when you have a little redness around an incision. We put them on antibiotics. A true infection, which in liposuction cases is going to be called cellulitis. And that's a case where the skin shows a patch of redness. Okay, if we did an arm and maybe a patch, that becomes red and tender and hot. And that's a little bit different from just an incision, a redness, because that's actually traveled a bit and the bacteria's gotten under the skin further back and caused an area of true infection. That may happen once, maybe twice a year. So we're talking about a true infection rate of 1 in a few hundred. the patients. That's not nothing. And when our patients tell us, hey, I have a painful red area, we jump on it. I tell them if I need to start them on antibiotics, I will. Oftentimes I'll tell my patients, get to your normal physician or an urgent care center where a doctor can really look at you firsthand and just kind of check all your other vitals and everything too. And I'm saying this because our patients are, the majority, 90% or more, are from out of state. So although I can call in an antibiotic in some places, and we try to do that regardless, I also like to have my patients see a doctor locally as soon as possible also, so that we have, two sets of eyes on it.
So yeah, it makes sense. We see occasional irritation, but usually in general, just compared to orthopedics, general infection rate is about 3%. And from what you say, a couple,
we have about
patient,
0.5% or less.
Which is, it's less than 0.5%. So it's very, very low.
So typical surgeries, I mean, I can tell you right now, the infection rates from other surgeries in hospitals is usually about 3 to 5%. And, so that's 5 in every 100 patients. If that was my rate, that would, if we looked at my 500 patients, that would be 25 patients a year. But ours is only like 1, maybe 2 that actually have, more of a developed redness. And I can't think of the last time we needed to go beyond just, normal antibiotics, oral antibiotics. I think it's been several years since we actually asked anybody to go into the hospital to get IV antibiotics. But that's one of the things that we have to watch out for. We always ask patients to help us out. When you call us early, then we can treat things early too. Safety, that's what we're talking about. You do sleep surgeries under general anesthesia all the time because you have to.
Right.
So maybe I'll defer to Dr. Kardashian about the rate of blood clots. We're talking about DVT, deep vein thrombosis, which can travel and cause a pulmonary embolus, which is a life-threatening condition. So all surgeries where patients are put under, we have to, doctors in general, surgeons in general, have to be concerned about a blood clot risk. So this is a real concern under general anesthesia.
Of course. And what people do if surgery lasts for a considerable amount of time, especially more than 2 hours, it's an automatic application of sequential compression devices that go on patients' feet to prevent DVTs, deep venous thrombosis, blood clots formation, because it's a real risk. Because if you don't move, your blood doesn't circulate as well, and it has a tendency to form blood clots that can go into your lung and kill you.
Right.
And so in our case, this is the opposite. Patients are working out, they're tensing their muscles, their blood is moving all the time, and so that risk is mitigated.
So the blood clot risk we're talking about happens in the back of the calf. There's a particular vein back there that when blood flow is not flowing through there as readily, it becomes a little bit more still. That's when it coagulates. Now, what keeps it from coagulating normally is that your muscles are always moving. Just even when you're sitting and sitting still, you're still fidgeting and your muscles are tensing. It's acting like a pump to keep that blood flowing through the vein. So the risk during general anesthesia is that patients are paralyzed, meaning they're put to sleep, but their muscles are given an agent through the IV that stops all muscles from even from twitching. So as Dr. Kardashian mentioned, anytime you have a surgery that goes beyond 2 hours, that risk of a deep vein thrombosis or blood clot happening in the back of the calf goes up tremendously. Our surgery has you tensing your muscles like continuously. I mean, when I step back for a second so I can take a breather, I stay relaxed. But otherwise, as I go in, to do anything, putting in the anesthesia or using the cannula to break the fat free, I'm saying tense up, tighten up, tight. So you're tightening up your calf muscles, you're tightening up your thigh muscles, or arms if we're working arms. And because of this continual motion, your risk during the surgery of having a blood clot is almost zero. I'm going to say theoretically it would be zero because you're more active than you normally are. You're actually working out the whole time. Where there is a risk of blood clots is after the surgery. So when people are laying around in bed and not getting up on a fairly frequent basis, they are at risk for blood clots. So besides the first night, we tell you not to get up too much because there's a lot of lightheadedness. We don't want anyone fainting. Beyond the first 24 hours, we actually ask you to get up and move around at least every hour to hour and a half, even if it's for a few minutes, just walking across the room to the bathroom or to the kitchen or something. That does not include when you're sleeping, because when you're sleeping, you're also tossing and turning, flipping back and forth. But there is always a concern of blood clots. I think just to let you know, we've had one blood clot in 18 years, a deep vein thrombosis in my patient. That happened 30 days after the patient was done with the surgery. And I can tell you why it happened, because she was so swollen, she was uncomfortable, she was spending too much time laying down and not being active enough. And it's understandable sometimes that, you don't want to move too much, but the point here is that it's a very safe surgery. Surgeons of all types, with a general surgeon that does a lot of intra-abdominal surgery, cardiothoracic surgery, orthopedic surgery, the risk, every surgeon can tell you they have a blood clot once or twice or even more than that in their patients every single year. From a normal, this is a normal, kind of expectation. And we've had one in 18 years. So that lets you know that it's not something to worry about, but it's something that can happen, and our risk is very low.
And also some patients have genetic clotting factor problems that can predispose them to having these problems. And so that patient may have had that issue without anybody knowing. That's also a possibility. But before any procedures, blood gets tested, and we make sure that clotting is okay. The clotting levels are fine before the procedures.
We are very complete in doing a medical assessment of your medical history with labs and going over all the risk factors that you may have. I think we do a much more complete job than most doctors do. And my background is in internal medicine. That was 18 years ago, and I practiced internal medicine for 8 years prior to that. And my job was, in many cases, to do the preoperative evaluation for patients who are about to undergo surgery, because that's who does it. It's a primary care doctor. It's an internal medicine doctor. So I get to look at everything, and I do have that background to identify risks, and where I don't have the expertise, if it's a specific area like a hematologist area or a pulmonologist has to get involved, well, then you have to go and see your specialist. But we do a very complete evaluation before patients ever come to us. So I think, so from talking about risks, there was the blood clot risk, that we were talking about infection, and then bleeding. Everyone bleeds. And I can tell you right now that, again, Dr. Kardashian, who does a lot of, who does more traditional open surgeries, not just, liposuction, has seen all that type of, aspect of surgery where patients may need blood.
Absolutely,
right?
Absolutely. It's it happens, but it happens usually with bigger surgeries.
Yeah.
So
right. So with all other types of surgery, that becomes a much more common thing for blood loss. We always have blood loss in liposuction, but it's usually a very small amount.
Minimal, yeah.
And it may be enough to detect and see that the blood count may drop 10, 15, even up to 20% in some cases of a large liposuction of your legs. But even a 20% blood loss is something that is not going to require a blood transfusion. It may have you feel tired and weak, for a few days. And we don't always repeat our blood count, our blood labs. But if anyone is feeling poorly or more worn out, we always check that. And in the 18 years that I've been doing liposuction surgery, I think we've had 3 patients that have had blood that has been given to them after the surgery because they lost more. So that is, if you talk about surgery, that would be minuscule, right?
Oh yeah,
minuscule.
absolutely.
So again, not something that we want to gloss over and say can't happen, but if it does, it's a very rare occurrence. And I think that covers the most significant risks. I mean, I don't want to get into all the minutia, but we talk about bleeding, infection, and blood clots being the most significant surgical risks, and I think ours are extremely, extremely low. Let's get into the questions again, see if there's anything else that we want to cover here. Why don't you, this is from Disa. Thank you for your question. What is the reason that you don't suggest MLD or manual lymphatic drainage starting the day after surgery to help move fluid? I'm going to tell you, there's differences in everything from that I do compared to what some of the other doctors do. And somebody just comes down to background, how we've always done things. So we all have differences in the instruments we use, our techniques, our aftercare, and everything else. And no one's established an exact yet. But I'll tell you why, in particular, I want my patients to hold off of MLD, manual lymphatic drainage, for 1 week. Although some doctors say you can start the next day, and I've talked to physical therapists that say, oh yeah, it's perfectly safe to start the next day. We actually see seromas, and seromas are some doctors will call it a complication. I like to call it a delay in healing, because after you do liposuction, here's the muscle and here's the skin. They have to stick back together because you've removed what's between them. So now you have an empty space and the skin can move around freely, and you have all this fluid that's coming into the area as part of the healing response. And that fluid is going to move into the tissue that's remaining, and it's going to swell up as a solid layer when it happens, when the 2 surfaces have stuck. But before they stick down together, that fluid moving in can create a little bit of a pocket. And that pocket, as the fluid gets bigger, can just create an isolated pocket in some place, and that's called a seroma. Seromas are a risk in almost all types of surgery: intra-abdominal surgery, tummy tuck surgery, breast surgery. So where there's been a lot of tissue plane separation during the surgery, this is where fluid can move into it. The skin is sticking down to that muscle underneath it very rapidly. And it typically would be fully stuck within a few days, 4 or 5 days, if everything went right, okay? And in the higher areas of the body, whether it's the tummy, the arms, where we're doing liposuction, seromas are not very common. But down in the legs, where I do surgery very completely, it increases the risk of a seroma when you remove fat very completely. I haven't done a study on this, but I'm just talking about it, from a common sense standpoint. The more disruption of the tissue and the more complete everything's removed, there's been more injury, more fluid's going to come in, and it's going to be more difficult for those layers to stick together. So we're in kind of a race against the fluid coming in. When it's down on the lower legs, that's where most of the swelling occurs. And you want that skin to heal as quickly as possible, but sometimes the fluid moving in beats the tissue sticking together, and that's where you get that seroma. That's one of the reasons why all patients wear compression garments, to hold that skin against the muscles as tightly as possible. Not tightly as possible, but to hold it tightly there so that those 2 surfaces are touching each other. If they're not touching and there's a layer of fluid between, they can't stick. So what does this have to do with MLD? MLD is massage. It's a very light touch massage, but I have seen cases where the massage therapist that patients went to did not understand MLD. They may have said that they do, but they did not. And there's special training for MLD compared to regular massage. So imagine this: the skin is trying to stick down, but you have someone who's doing this. What's that doing? It's separating or causing the potential separation of the skin from the muscle beneath it, so that you're loosening the skin versus helping to tighten it. That's why I like my patients to have a whole week for that skin to stick down as much as it can before you start doing the MLD. And now that we've talked about seromas, I know that some of you out there are probably going, oh my God, what's a seroma? How do I prevent a seroma? Well, we have been putting small little drain tubes, a little piece of rubber tubing into the incision, going in about 1.5 inches to 2 inches. And we do this in a couple of strategic spots where almost all the seromas happen. And what that's done over the past 8 months or so since I started doing that is it's reduced the seromas very significantly. Do we still have them? Yes, but it's something that may only happen a couple times a month now. And when you do get a pocket like that, patients call me right away because we let them know what to look for before they leave our office. And if it does appear to be a seroma, we have them wrap outside of their normal compression garment, take an ACE wrap and wrap it fairly tightly to squeeze down that fluid and spread it out. And most of the time that's enough to get the pocket of fluid to move out of the way and for the skin surface to attach. In the cases where it doesn't, which may be once every month or every other month where that seroma is not resolving by compression alone, I do have to fly patients back because your doctors in your local area are not going to know how to deal with a seroma. They don't see it too often. And even if they do know what a seroma is, they're not going to want to mess with it. If you go ask another plastic surgeon, can you take care of the seroma that was caused by ArtLipo? And they're going to say, no, go back to ArtLipo. I'm sorry, but that's how it is. Most plastic surgeons will not want to take on someone else's patient. So I would pay for your flight, fly back down. We put in a tube, it all drains out, and then you go back home and you pull out that tube in a few days and it's all good. So seromas are very easy to take care of, but they do take maybe a day out of your time if we have to fly you back down. And we, like I said, we pay for the airfare so it doesn't end up costing you anymore. I think that covers two things. Let's see if we have anything. We have about 10 minutes left. Are antibiotics, this is by Wendy F. Are antibiotics absolutely necessary for lipo of the legs and arms? What do you think?
Antibiotics are
they absolutely necessary?
They're not absolutely necessary, no.
Yeah.
I think humans have lived for a long time without antibiotics. That appeared only in 1945. But they help to minimize any things that we're concerned about, that redness that develops. They can minimize the risk of that. And it's not a great risk, but it exists. And antibiotics in general are not harmful. And there's a question about antibiotic allergies. So we go through, we talk to the patient, go through the list of allergies. And there are different classes of antibiotics. And we can definitely avoid the one that gives a patient allergy and prescribe another antibiotic that is safe for that patient and that is just as effective as the standard antibiotics we give that you're allergic to.
Okay. So without getting into like a big debate about this, I can tell you that over the years, there are groups in the medical field that have suggested that surgeons like orthopedic surgeons or cosmetic surgeons or any other type of surgeons don't give all patients automatic antibiotics. And the reason is because that giving everybody more antibiotics than we need to can increase resistance of different microorganisms. That's one of the arguments. But there's also other arguments that, besides the allergies that can happen, antibiotics can interrupt gut bacteria, and when that's interrupted, there are some, potential complications, overgrowth of bad bacteria and things. So I fully respect someone's decision not to take antibiotics beforehand. There has been, there is a small increase in, preventing an infection that, doing it preventively versus treating it afterwards. But it's a personal decision. I think a lot of surgeons have struggled with this question. Should they continue prophylactic antibiotics or not? And there's still many surgeons that do it. So I'm still doing it, but I'm happy not to put you on antibiotics if that's your choice.
Okay.
All right. Let's see if
Sounds
there's
good.
anything else. Okay, let's see if we have, this is Melissa. Thank you for your question. She asked, the holes, do they leave bad scars or will they fade for the most part? We're talking about the incisions, and there's quite a few incisions. I'm not going to hide the fact that I use a lot of incisions, and I think by using incisions, more strategic but more freely than other surgeons, that we are able to travel the contours of our sculpting in a much more accurate way and much more complete way. However, there are more holes, and I've always been a proponent of holes are not going to be as disappointing to a patient or incision sites as it is if you don't remove the fat completely or if you leave it lumpy and bumpy. So I believe that making more holes in strategic manners helps prevent the other part, okay, the other lumpy and bumpiness. So in any case, if you're someone who has lighter skin, Caucasian skin types, your concern about holes should be very minimal because they heal up so well. They're hard to see, even if you're sitting as close as Dr. Kardashian and I to see. You'd almost have to kind of look like, oh, there's one right there. You have to look so closely. However, for people with darker skin types, Asians in particular, have a propensity to darken at the incision. So they look like little dark brown spots for maybe a year or even up to 2 years sometimes. And then if you know that you hyperpigment, we're talking about hyperpigmentation now. Hyperpigmentation on people where some African-American skin is also prone to this. I would say darker skin types like Latin or Hispanic skin, it doesn't, it's not as correlated there, okay? However, we will, if you have any questions about this, please ask. And it's one of the things that we can't get around. I can reduce the number of incisions on some patients. Like when I have an Asian patient, because she has hyperpigmentation really easily, I can reduce the number of incisions, but I can't do that significantly without sacrificing some of the results. And then the other aspect of holes is, do they scar? Or, do we see true keloids? Very rarely. If you know you have keloids, you better let us know, because then you have a high chance of keloids. But actually, true keloids are very uncommon. And even feeling a raised bump, okay, so basically, will we have a lot of scarring? Scarring is what I define as a raised bump. If you drag your finger across an incision and you can't really feel it, that's not really a true hypertrophic scar, but you may be able to see it because of the darkness around it, which is hyperpigmentation. So I think we're out of time right now. And I think what we're going to just, we want to make sure that we answer is patients who are wondering, how do we get a consultation? Go to our website. There's a consultation button. It's a virtual consultation. It tells you, when you answer it, it'll have a questionnaire for some basic information, as well as photos. Photos are the most important thing. And unlike other doctors, photos are, we utilize them in such a way that you send us your photos, I draw, or one of my staff draws on your photograph, and we get to see the change and what the new shape is going to be. We get to indicate where the, any looseness of the skin and wrinkles may be. So it will give you a really good idea of what your leg size, shape, and how everything's going to look afterwards. So go to our website, go to the virtual consultation and fill that out. And this is a much more effective way to give you an initial idea. Our consultants will spend all the time in the world answering all the questions also for your consultation. Thank you.
Thank you, everybody.
For years, I suffered with lipedema. It affected so much more than just the cosmetic aspect. It affected my relationships, my job, my mobility.
It's not all about the aesthetics. It's about restoring quality of life. It's about relieving pain, and it's about restoring the patient's confidence.
It's not just about how I look, it's about how I feel.
We've treated